Hello, everyone, and thank you so much for joining today's webinar. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. No one in control of the content today have any relevant financial relationships with ineligible companies. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we'll have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. Please use the Q&A feature for questions and the chat feature to interact with other participants. We'd like to thank our speaker for sharing their expertise with us today. Of note, thoughts and views expressed are that of the presenter and do not necessarily reflect that of Sigma. We are proud to provide this webinar in conjunction with the American College of Lifestyle Medicine. Our presenter today is Kelly Freeman. Kelly is the Director of Workforce Development at the American College of Lifestyle Medicine. Previous roles include lieutenant in the United States Navy Nurse Corps, case management, wound consultant, legal nurse consultant, adult geriatric primary care NP, and university faculty. She attended the University of Nebraska as an undergraduate and received a master's degree as a primary care geriatric nurse practitioner at Indiana University, USA. She holds 2 postgraduate certificates from Indiana University in Public Health and Nursing Education and is a PhD candidate in health policy. She has also co-authored 4 book chapters and has co-written research papers on lifestyle medicine reimbursement, shared medical appointments, provider burnout, well-being, and cost savings. We are so thankful to have Kelly today, and we're going to turn it over to her.
Thank you so much, Linda. It is a pleasure to be here with all of you today. I'm very grateful for this opportunity. And we are all here just to think about and talk about medication challenges that we may be dealing with. And so let's go ahead and get started. And I do have just a couple of disclosures. First of all, part of my work is supported through a grant by Ardmore Institute of Health. Ardmore Institute of Health is a nonprofit that supports clinicians to move therapeutic lifestyle interventions into their practice. And you can find out more about them at ardmoreinstituteofhealth.org. Also, I am employed by the American College of Lifestyle Medicine, but as Linda mentioned, all relationships have been mitigated. So our objectives over the next hour, and we really are going to get through all this, is we're going to look at the connection between medications and individual population, environmental, and economic issues. We are going to describe how to utilize medication data related to number to treat and harm and absolute and risk reduction to risk reduction to better understand risk and excuse me for a second here, the medications. And then also assess opportunities to mitigate the downstream effects of medication management in complex chronic disease, especially related to polypharmacy, pill medication burden, costs, prescription cascades, medication access, contamination, and adverse effects or reactions. And so I understand this is a lot in one hour presentation, and actually we're going to do this in about 50 minutes, so we have some time for questions. But I really do want to focus on the second one, and we're going to do that. And I think it's super important for nurses to have this type of information. So what we're talking about today is only medications related to chronic diseases. And we know that chronic diseases are the leading cause of death and disability in the United States and in many parts of the world. In the United States alone, it's the leading driver of healthcare, adding to the nation's, or costing the nation $4.5 trillion in annual healthcare costs. Now, for adults over the age of 18 in the United States, 4 in 10 have at least one chronic disease, or 6 in 10 have at least one, 4 in 10 have 2 or more. So this is a substantial amount of chronic disease burden within the United States. And here's what I know. I've been a nurse for over almost 35 years. I know nurses can lead the way for a healthier global population with much less chronic disease burden. But we've got to have the information, the data, the resources to really make a difference. And so one way we can do this is just by looking at the chronic disease guidelines and really exploring them and making certain that we are following them. These are evidence-based guidelines. And let me give you some examples of these. These are some that you can find readily on the internet from the American College of Cardiology, American Heart Association, etc. And one thing that you are going to notice about every single chronic disease guideline is that first and foremost, we are to address their chronic disease through lifestyle interventions. And so it is stated in different ways, as you can see on this slide, but it's very, very important. The tricky part with this is, as nurses, how do we know exactly what that means and how to do it? There's a lot of noise out there as far as what type of dietary pattern or how much activity, how much exercise, etc. And so these guidelines are very specific related to medication dosage, but not so much related to lifestyle dosage. So we're going to talk a little bit about that. But we do know that in the treatment for chronic diseases, therapeutic lifestyle interventions in many cases can be just or more effective than medications, but without the side effects. And especially if disease remission is the goal, then we must address the underlying, often lifestyle-related causes. And so we'll talk about that too, and how to do an assessment. There are multiple lifestyle assessment tools available online, and these give you a few examples of these. Just do a quick search and you can find them. And why is it so important to do this? Because if you don't know your patient's health behaviors, their lifestyle, you're missing out on knowing the opportunities there are to benefit them in ways related to lifestyle change. And I want to give you just one example of that. And this was a patient that I had seen as an NP who was on a very, very long list of medications, and an overwhelmingly long list, and he looked very, very sick. He was an outpatient, and I just asked I asked him a question, and that question was, "What did you have for breakfast this morning?" And he told me a donut. And I said, "Oh, okay. What did you have for dinner last night?" And he told me pizza. And so I asked him if those were his favorite foods, because I wanted to get an idea if that was mainly what he ate. He started crying, like sobbing uncontrollably. And when he started talking to me again, he said he'd been so sick and he couldn't drive. And the person that was bringing him food would only bring him donuts and pizza. That's all he had been eating for months. So these lifestyle assessment tools are incredibly important and easily available. Now, there are some health systems that are even moving these lifestyle assessments into their EHRs. So you can see that in some Epic EHRs. And so that's an opportunity as well to get this type of information. All right, but we know there are challenges to this. We only have so much time. However, as nurses, we're frontline, we're seeing those patients, we're with them doing other things, and we can also work on lifestyle at the same time with them. There may be some uncertainty as whether a change in lifestyle really makes that much difference. Does it? We're going to look at that. And then it does require some support, and there are a lot of tools available to help with this, which I will include at the end of this presentation. And then finally, there are expectations from our patients. Our patients may have seen a commercial that tells them how great a medication is that does this or that, and they come to you and to your clinic, to your health system, expecting that they will get that medication and those results. All right, so let's take a deep dive into some issues related to medications for chronic conditions. Let's just for a moment focus on antihypertensives. And these are incredibly important medications. Okay, so I don't want anyone to get me wrong here. We all are nurses. We help make sure patients manage their medications. We are frontline in making sure that medications are part of healthcare, and that this is certainly the case with antihypertensives. We want our patients who are hypertensive to be treated. It's super important. And what we know is that on average, just one antihypertensive medication decreases the systolic blood pressure by about 10 millimeters of mercury, which reduces stroke and heart failure risk by about a quarter. And we all know we do not want our patients to have a stroke or go into heart failure. So incredibly important. However, we're dealing with a lot of side effects here. Some people can take these medications and do very well, and that's wonderful. But then we have some who deal with these types of side effects, may switch from one medication to another, still are dealing with side effects. And that becomes problematic in that they may decide that they don't want to take them anymore. Medication adherence is a huge issue. About 50% of people with chronic diseases do not take their medications. About half of them do that intentionally. And then the other half, just because it's too much burden, they forget, etc. And so I hope the word noncompliance is out of our vocabulary, but at least for a long time in nursing, we would chart all about how a patient refuses to take their medication or forgets it or doesn't want to. And so of course, we used to call that noncompliance, but instead let's call this person-centered care. And so we need to find out what barriers are in the way of that person taking the prescription medication that they need. And if those barriers can't be removed, what are other options? And possibly are there other options anyway for them? All right, so what about lifestyle for hypertension? So what do lifestyle interventions do for the blood pressure? Well, this one meta-analysis was able to find the mean of decreases in blood pressure, systolic and diastolic, for a number of lifestyle interventions. And so you can see them listed here. And think about that one medication that we can use to decrease systolic by 10 millimeters of mercury. Well, if we can get our patients to do some of these lifestyle interventions, we can pretty quickly add up to that 10 millimeters of mercury. So especially when you have patients who are even pre-hypertensive, if we can get them to do some of these things, we can get their blood pressure back down to normal. And that's really exciting work. And besides the results from this meta-analysis, there are also other examples of lifestyle interventions that are known to decrease blood pressure, and those include increased fiber intake, increased dietary magnesium and calcium. So we don't mean just pills, but we mean foods, fruits, vegetables that are high in magnesium and calcium. Relaxation techniques such as breathing and meditation, hibiscus tea. And then finally, decaffeinated green tea. So there's a whole bunch of lifestyle interventions that as nurses we can promote, suggest to help get blood pressure lowered. I do want to warn you though, it works really well. And so if you have someone who is on blood pressure medication and they're making these significant changes, they are going to need deprescribed off that medication likely pretty quickly. So we need to be watching them closely, and if they're and making sure they know that if they're having any side effects, such as dizziness, lightheadedness, that it's probably time and that we need to check their blood pressure again and see if they need to continue on that medication. All right, so we've already discussed quite a bit, but we are going to take a deep dive now into some medication challenges that we likely have all seen in clinical practice, and just some ideas about what to do about all these. So we'll talk about polypharmacy, high pill burden, prescribing cascades, medication costs and contamination and side effects, as well as water contamination and supply issues. All right, so first, polypharmacy. We've all seen it. We see a patient with a long list of medications. Polypharmacy is normally defined as someone taking at least 5 medications for 90 days. So this is not that short term, someone's very sick, they're on a lot of medications, but at the 90-day point, what are they still on? It can also be defined by appropriateness. So if you have someone who is taking inappropriate medications, or they're taking duplicate types of medications, or even taking medications for for adverse effects of another medication, then those are all defined as polypharmacy. And how common is this? Well, at least in the United States, 37% of adults are dealing with polypharmacy. And for those over 65, it is 45% of all adults in the United States. So it's a large number of people. And the problem with this is that there's a lot of problems with this. So we see increased drug reactions every time we add another medication. There's hospitalizations, functional decline, increased death, and increased cost of care. And so let's just look at the increased cost of care for polypharmacy. And this study was done in a way that the people that do experience polypharmacy were very similar to those who didn't, as far as their disease and such. It's just that the one group was prescribed and taking a lot more medications. And on average, the people who experienced polypharmacy had a total healthcare expenditure of $19,000 a year over that, whereas those that didn't, it was around $8,800. And then even their drug costs were about 3 times as much for those who experienced polypharmacy. So this is really quite an issue, and we as nurses can help prevent it and stop it. And how can we do this? Well, there's lots of different opportunities for us. Certainly looking at these medications and just even asking ourselves, what does this person really need to be taking here? Is there anything that's a duplicate? Working closely with the provider or prescriber. If you're not an NP or CNS have prescribing privileges, work closely with that person that does. Work closely with the pharmacist. There is one tool that I absolutely love. It's called the STOP criteria. That is the screening tool of older persons' potentially inappropriate prescriptions. And then there's also the Beers criteria. It's really great for nurses to know these. There's some digital technologies, and there's actually some AI out there that is looking for and identifying polypharmacy. And then we also can look at deprescribing guidelines and initiatives, and there are more and more of these all the time. When I started nursing so long ago, and up even till about 10 or 15 years ago, it was thought that once a patient has a chronic disease, once they're diagnosed, they're going to be on that medication for the rest of their lives. But what we know is that as people get older, they can't tolerate these medications. And in many cases, we really do need to get people off of medications. All right, so something that kind of goes with polypharmacy is a high pill burden, but it's also just a little different. It is defined as the number of pills per day or week, and probably a better way to classify this would be medication burden. And the reason for that is because we know we also have infusions and injections and topical treatments. And so lots of different types of medications that may be a burden to our patients. It adds to their medical complexity, and it also can lead to errors and decreased medication compliance. And let's just think for a moment about errors. And as nurses, and let's say either you're working in long-term care or in the hospital, and depending on the number of medications you have to pass within 1 hour, your chance of an error is going to go up the more medications you have, and the more just so we just need to keep that in mind, that if we can keep our patients on what is a reasonable number of medications and the ones that they really need, that is giving us back more time to do other things with our patients and to really have the time and space to concentrate on our work. Okay, so a recent study was done that looked at medication burden for people with type 2 diabetes. And what was the end of this, or one of the resulting statements, is that not only patients, but also practitioners or prescribers, pharmacists, and payers can benefit from interventions which decrease medication burden, complexity, and or adverse events related to the treatment of type 2 diabetes. So again, looking back towards those lifestyle interventions, there's a tremendous opportunity in the type 2 diabetes population to implement lifestyle change. It can really make a difference. So as nurses, you do have some resources for you to help assess whether a patient has medication or pill burden. And so I've just listed here a couple of these questionnaires, but I also think that you probably can just see it, right? You see a long list. They're complaining about having to take so many pills. They're having difficulty swallowing these pills. They can't find their medications. They're having trouble keeping track of them. They're complaining that their medications cost too much. Or that they're having some side effects, and the schedule is overwhelming. So there's a lot that you are able to see that possibly the provider is not able to see, just because they have such a short amount of time with them. You can also ask your patients some questions about this. Are they finding that the medication is helping? And do they have the knowledge and ability to take the medications correctly? And if they're not taking them correctly, could they be doing more harm than good? Is it a dangerous situation? How much is this medication costing them? Are they able to get the medication? And what other difficulties might they be having to taking these medications? And just a really big question that's kind of hard to ask, but it's an important one, is does that individual who the medication is prescribed for actually want to take the medication? Is it their desire to take this medication, and are they going to do it? All right, next challenge that nurses are dealing with our patients are prescribing cascades. Now, prescribing cascades can occur when a new medication is prescribed to treat the adverse reactions of another drug. So when the prescriber believes that a new medical condition is actually developed, or, and this is one that nurses are really good at, we know this, we do this, when an adverse reaction to a drug is anticipated, so another medication is prescribed. You've all seen that. Some examples of this are when we're treating edema with diuretics, when we're using calcium channel blockers, or here's the big one we've probably all seen over and over again, is when we have laxatives prescribed, or we're using laxatives for constipation due to opioids. But then also NSAIDs can cause hypertension, and so people can end up thinking, or even prescribers will diagnose people with hypertension when they're taking an NSAID, such as Motrin, Advil, for pain. So again, these prescribing cascades are incredibly common. You want to watch out for them. And then next challenge that we can be dealing with here, and especially in the United States, is medication costs. And so let's just hone in on what we're talking about here. So lots of numbers that you can explore if you want, but let's go to the bottom of the screen there and see what's highlighted. So just in 2022, prescription drug spending in the United States increased 8.4% to almost $406 billion. And that was faster than the 2021 rate, which was 6.8% growth. Now, this is a lot of money, and we have a lot of sick people in the United States. It's not, so the expenditures for these medications are not specifically making our population as a whole a lot healthier. Overall expenditures in the United States just last year increased 13.6%. This is an astronomical amount of money. So $722 billion spent on pharmaceutical agents in the United States just last year. And I mentioned that medication in the United States is more expensive than other countries, and this is just one example. These are the weight loss medications that are commonly being used, and you can see that they cost about $1,000 on average, around $1,000 a month in the United States, way, way more than any other country. Now, the US is starting to do some things about the cost of medications. The government, Center for Medicare and Medicaid Services, is beginning to negotiate prices, and they have a list every year of what medication, what medications they will be negotiating prices for. And I don't know why it's a short list, but it is. But you can go on their website. The Kaiser Family Foundation lists the different negotiating meds for each year. Now, as far as policy goes, one very interesting intervention that's happening in the state of Florida is that Florida proposed to the FDA that they wanted to purchase medications from Canada to save money on medications. And they actually have been able to save a significant amount of money. And so I've been looking around to see if any other states are doing this yet. I don't think they are, but this is an interesting situation that's happening there. And so these costs, most people think are unreasonable. About 79% of people polled in the United States feel that the costs of medication are just unreasonable, although 38% do feel like their medications do make them a lot better. And it's tricky with chronic disease medications because in many cases, we are trying to prevent something else, right? We're trying to prevent a stroke, a heart attack, bone fractures. So a lot of times the medications that our patients are taking to them may not seem like they're making them a lot better because they're preventative. They're not maybe seeing that it did prevent them from having a stroke, etc. All right, in case you haven't heard of this terminology, I wanted to just give it a shout out because it's getting quite a bit of attention these days, and that is pharmacy benefits managers. So these are entities or intermediaries who basically decide the drug prices. And so the government is starting to step in and figure out like, how is this beneficial to the consumer? What's going on here? And there are some things that are being done. So this is good news. Hopefully the drug prices will come down. Some really good news is we now have some pharmacy public benefit corporations. So be looking out for these. Cost Plus Drug, Flow, MAPS, Viva are all in different stages of development. And so these entities can offer online or by mail medications at a significant cost savings for our patients. And then these same types of corporations are also starting to manufacture medications in the United States. So many of our medications within the United States come from other countries, and this is a way to manufacture here in the States. So you'll be probably seeing more and more about these in the future. Okay, we're going to switch gears again to another medication challenge that we may be dealing with, and that is contamination. And although it thankfully does not happen that often, there are situations where medications can make people sicker because they are contaminated. And there are some different types of contamination. It can be from bacteria or mold, but then also it can be from the process of manufacturing where there's a foreign object or body that gets into the manufacturing process. And so there have been situations where there's been glass or rubber. And then a few years ago, something that occurred that was found in medications was NDMA. And so there were some medications that were pulled off the market because of that. And the NDMA is known to be a carcinogen. And then finally, even gluten. Some medications do have gluten, and then we do have people that cannot tolerate that. We don't want them to be exposed. Something to keep in mind with all medications is they must have fillers, right? There's got to be some way to propel the medication into the human body. And so it adds bulk and structure and performance to the medication. And we don't know what those ingredients are. They're different for every type of medication. They don't have to be listed on the label. And so for some, these can be problematic because people can have allergic reactions to whatever the filler is. There can be some toxicity or sensitivity. And just one example of this is for people who are sensitive to dyes, say whatever colored dye. Many of our medications are colored and they use artificial dyes to color them. Okay, and then medication side effects, which we are all very aware of. We do have some that are pretty intense though and end up to cause emergency department visits. These 4 medications are the most common for this. So the anticoagulants, bleeding because of those, the diabetes medications causing hypoglycemia. Now you won't see this with metformin, one of our basics that we use, but with many of the others, we can have some severe hypoglycemic episodes. Benzodiazepines and then prescription opioids, along with those that are obtained otherwise, cause people to end up in the emergency department. And so this is actually fairly common. 0.5% of Americans had an ED visit in last year. And for those over the age of 65, 1 in 80. And of these people that went to the ER seeking help because of a medication side effect, nearly 40% of them were hospitalized. So their medication side effect was that severe. And so why did they end up in the hospital? And there's different reasons, but one example of this is drug-induced nephrotoxicity. We want to be really careful with our kidneys. We only have 2 of them. They're super important organs in our body. And there are issues with some medications causing acute or even chronic types of kidney injury. And so what medications are suspect to this? You can look up a full list online, but there are some pretty common medications that have been known to cause kidney failure. And I just listed a few here that start with the letter A, but we always want to watch out for the kidneys. We want to know what the creatinine is and really just love those kidneys. All right, so next, let's move on to water contamination and what that looks like. So this is when our water is contaminated with medications. And there are a few different reasons that this happens or ways that this happens. One is just through the use of medications. So when people use medications, they have some leftover meds and they dispose of them, perhaps flush them down the toilet and they end up in waterways, or just through elimination as well. So that's human medication use. And then through the pharmaceutical manufacturing process, we have to be super careful that the medications as they're being manufactured don't end up in waterways. And then finally, and another, this is a big one, is livestock use. So when we have these confinement operations for meat-producing animals that are taking antibiotics and hormones, then that does tend to get in the waterways as well. And so what does this look like for us? Well, there are there are at least 127 researchers in multiple institutions around the world that are studying this. And so if you're interested in this, you can go to globalfarms.org to find out more. You can see at the bottom there in the United States, there were multiple medications that they found had the highest levels. Depending on the region, area of the country, there can be different medications that can be found in the waters. Another study looked specifically at aquatic creatures, so fish, and whether or not they had the medications within them from the contaminated water, and they did. So not only is it in our water, but then it also gets in potentially our seafood. So what can we do about this? Well, in general, we don't want to flush medications. That is just not the best way to get rid of medications. We want to use specific methods or disposal sites, including drug take-back programs. Those are wonderful. Get your patients to take their unused medications back to whatever pharmacy or place is taking drugs back. And then also, we want to try to just make sure the patient has exactly what they need and not a lot extra as far as any particular type of medication that might get wasted or dumped. All right, and then let's now explore medication supply issues, which I am fairly certain all of us have seen much more of this over the past 4 years or so with some disruptions in supply. The FDA does have a website specifically for those in the United States that monitors the drug shortages. So there's a database there that you can explore. There, you can also find out which medications you can extend their use dates. And so this is super important. If the medication is listed there and they say you can extend the use date, wonderful. You don't have to waste that medication once the due date has passed. And then also, as a nurse, when you find that there's a new shortage, you can report it through this FDA website. Now, why are we having all these medication supply issues? Lots of reasons. There's been some difficulties with acquiring the raw materials to make these medications. There's manufacturing issues, regulatory issues, even business decisions. Drug manufacturers may just find that some medications are not profitable, and so they stop making them. Transport issues, and then a big one that's happened over the last few years as we've gone to more virtual types of clinical visits and being able to prescribe online. There's been a lot more of that, especially in some areas, for instance, ADHD medications. And so that has totally shifted and increased the demand of those certain medications. And there are some consequences to this, and I know you're all seeing this. Our patients are being delayed as far as getting their treatments. We may have to substitute for their therapy, and then also there's the emotional burden of this. It's very stressful to be able to try to figure out, where do I get the medication I need, and am I going to be able to find it? And so a lot of that we need to deal with as far as this goes. So I know I've talked about a lot here, but I do want to bring up just 2 other medication challenges that you will see. Number 1 is the direct-to-consumer advertising. And so there's only 2 countries in the whole world that do this, and that is the United States and New Zealand. And there are reasons that most countries do not do this. These ads have been shown to misinform patients by overemphasizing treatment and underemphasizing the treatment risks, and then also promoting drugs over healthy choices. So we don't have commercials saying, hey, you should do this instead. This is really helpful. Instead, we have these medication advertisements. And in one study, what they found, looking at 97 of these pharmaceutical advertisements, is that there was very low quality data, and only 26 provided quantitative information of the efficacy or benefit of the medication. And then 0% provided any quantitative information on risk. 13%, and this even surprised me, promoted off-label use of the medications. Going back though to that quantitative information for risk, we're going to take a deep dive into that because you all can find that information out, and it's important information. So we do have at least one large medical society, the American Medical Association, that is promoting a ban on this direct-to-consumer advertising. And so what their statement was is that direct-to-consumer advertising also increases demand for new and more expensive medications, even when these drugs may not be appropriate. And then what goes along with this is often our patients think that these medications are going to work way better than they really do. And in order for these medications to get FDA approved, they must be statistically significant better. They must improve whatever the condition is in a statistically significant manner. However, what does that really look like? What does that mean in clinical practice, and how does that actually benefit the patient? Well, we also find that there's an overestimation of the benefits of the treatment by the providers. So both the patients and providers tend to have a view that the medication is going to work better than it actually does. And so this is where we get to that second objective that is so super important for all of you to know about. And so we're going to spend a little time on this slide. And if you want, you could even take a pen and paper and write a few things down. You want to know the number needed to treat with chronic disease medications. And this is something that you can just do a quick search. AI can help you find the research that shows that information. You want the number needed to treat to be low. Okay, so what this means is this is the number of patients that are needed before one person benefits. So for example, let's say there's a medication for bone fractures, to prevent bone fractures. And so the number needed to treat is one out of 5. So that means we give 5 people that medication for that period of time, and we will prevent 1 bone fracture. So if the number needed to treat is like 1 out of 200, then that's not so great. 1 out of 5, 1 out of 10, 1 out of 20, that's good. Number needed to harm is the opposite of that. So that is an adverse reaction or event that happens with that medication. And we want that number to be as high as, or we want it to be like 1 out of 1,000 or 10,000. Or if you have a number needed to harm of like 1 out of 2 or 1 out of 5, then that gets a little scary if it's a big problem. So look at those number needed to treat, number needed to harm. It gives you a better idea and understanding of what that medication can do for that patient. And then also, you want to know the absolute risk reduction and not be so concerned about the relative risk reduction. Absolute risk reduction is the decrease in risk from taking that medication. The relative risk is a comparison between 2 medications, and that number tends to be way, way higher, and that number is often used when marketing to patients and nurses and providers. So know the absolute risk reduction. That's the number you're looking for. Don't really compare, or don't be too concerned about the relative risk reduction. And then also know your number needed to treat and number needed to harm. Okay, so let me give you an example of the relative risk reduction versus absolute risk. And this is just one study, and you can look up this study. So with statin, there was a relative risk of reduction of dying by 9%, which sounds really great, and that is. But in absolute risk reduction terms, the man's risk was reduced by 3.4%, and the woman's by 0.1%. So in this particular situation, if you're a woman and you're experiencing any side effects with this particular medication, it may give you pause and think, is it really worth it for you? And so really knowing these types of numbers is essential. And from this same particular study, we found that the findings underscore the importance for discussing absolute risk reductions when making informed clinical decisions with our individual patients. So this is precision medicine, right? Like this is, hey, for you as a male or female or in this situation, this is what we're seeing. What do you think? Person-centered care. You get to make it, your patient gets to help make this decision. All right, so in this, we've talked about a lot. I know I've, I have burdened all of you with so much related to medication burden issues we're dealing with our patients. And so now I just want to share some resources that I'm hopeful will be helpful to all of you. And let's start by deprescribing resources. Deprescribing.org is out of Canada, and deprescribingresearch.org is out of the United States. Both of them have resources for you available about deprescribing. And then also the American the American College of Lifestyle Medicine is working on some deprescribing resources for those who are implementing lifestyle changes and doing really well with it and no longer need their medications. It's like, well, how do you take them off those medications? What's the recommendations? We didn't have that type of information out there before, and there are some researchers that are really honing in on that and getting and working on getting that type of information to you. All right. And then as far as deprescribing guidelines that are currently available, they are listed here, and these can all be found through deprescribing.org website. All right, and then also going back to that patient-centered care, there are some patient decision aids that can come in really handy as far as medications and what to take and when and why. The Ottawa Hospital Research Team has put together an inventory of decision aids, and so you can just search for that and find those. And then also the Mayo Health System has some really wonderful interactive patient decision aids on statins and antidepressants. I don't know if they have any others, but I know those two are super helpful. And then also going back to number needed to treat and number needed to harm. I already mentioned that you can just do a search for this, and AI can help you find the research that and can point you to the research showing the number needed to treat and harm. But also there are some researchers that have done that work for you. So if you go to thennt.com, you can explore different medications and then also interventions. And it's a pretty easy to understand visualization of green, yellow, or red, depending on if the number needed to treat makes it a beneficial medication, or if the harm does not really make it a worthwhile treatment to utilize. All right, and just one more shout out to these public benefit pharmaceutical corporations. Find out about them. These are the ones that will be hopefully helping with supply issues, cost issues, and so we want to just keep track of those. As far as lifestyle medicine, there are many non-medication prescriptions and resources that you can utilize. You can be creative with all this. First, start with that lifestyle assessment, and then offer your patients some of these resources if you feel like they would be beneficial. First, explore them yourself. Get to know them. There are many documentaries that you can watch. There are apps, there are online cooking courses. Some of them are absolutely free, such as the Big Switch and Ardmore Institute of Health's Full Plate Living, websites, and different programming. So lots and lots of opportunities for you to help your patient through resources to change their lifestyles. You may have heard of food as medicine and food is medicine. Both of these are gaining traction and really getting the attention of governments and healthcare systems because they're really impactful. So food as medicine is more a general, dietary patterns can do immense good if they're healthy types of dietary patterns, and can make a tremendous difference as far as diet-related diseases. Now, food is medicine is multiple stakeholders working together to supply food, healthy food to individuals. So there's a bunch of different ways this is done, and you can explore within your community how they are, what's happening there. But these can be produce prescriptions. So someone writes a prescription for produce, and then the person is able to take that prescription to a farmer's market or to a grocery store and get that food for free. There's medically tailored meals that can be shipped to people's homes, medical nutrition therapy that dietitians work with patients, and there's produce boxes, just all different types of opportunities to get our patients healthy foods. So it's really some very exciting work. So it's I've thrown a lot at you. I know I have in this past 50 minutes. I'm grateful to do this. And what I want to share as we're closing here is, again, I know as nurses, you all are so impactful with all this. And so within your practice, you can assess for polypharmacy, assess for the quality of life your patients are having, taking the medications they are. What side effects are they having? What's their desire to take that medication? And then what is their lifestyle? And that lifestyle includes not only their diet and their physical activity, but also their sleep and whether they're using risky substances, how they're interacting socially, and how they're dealing with stress. All of that makes a tremendous difference. You can educate on so much related to medications, and then also the lifestyle interventions. So these are evidence-based interventions that are really impactful. And then also for those NPs and CNSs who have joined today, and midwives who have prescription privileges, consider pursuing deprescribing more. And I know this is a challenge. Like, this is new territory for us. There's not a lot of guidelines out there yet on deprescribing, and looking forward to the time when there will be many more of these. All right. And I mentioned that I do work for the American College of Lifestyle Medicine. Feel free to reach out to me, kfreeman@lifestylemedicine.org. I'm happy to support you in whatever way I can. We have a course that's available for nurses, absolutely free. If you want to just scan that QR code, it will take you to that site, and it's for 5.5 CME-CEs. And we'll just give you some, just a basic overview of lifestyle medicine, especially related to the nutrition pillar. And then also, if you do have a master's or doctorate in nursing or another health-related profession, you are welcome to explore certification in lifestyle medicine, where you will take a very deep dive into the efficacy of therapeutic lifestyle interventions, so that you have the knowledge and power to know when you're able to prescribe these interventions and what they should do for the patient. So I want to thank you all, and I'm going to take and also there's lots of references here. Please feel free to download this PDF and explore these references. And finally, I'm going to stop sharing my screen and see if there are any questions. So again, thank you so much for sticking with me throughout this presentation. I know it was a lot.
Kelly, this has been great. And as you can see, people are very excited and thankful for what you shared. I do have one question. We have just a few minutes. You mentioned the STOP criteria and the Beers criteria. Do you know, this is a two-part question. Is that built in any electronic medical record? Or if not, is there an place where people could download maybe a PDF and print it out for completion when they're interacting with patients?
Yes. Okay. So I do not know that it is in any EHRs, but I think that's a great question for all nurses to ask for their pharmacist. And then also the start and stop criteria, you should be able to download the PDF with that information. And then also the Beers criteria, you can find through the American Geriatric Society. I hope it's open access. If not for sure, they do have that. But there's also some articles written about it. So if it would be helpful, Linda, I can find some links and share those with you to share with the audience.
Yeah, that would be perfect.
Okay. Yeah.
And then we do have a question, Kelly. I don't know if you know anything about this. Do you
Okay.
know what is currently being done to limit the use of hormones or antibiotics in animals used for food? That's kind of a deep question.
It's, you know what, actually, that is a question that I've dug into quite a bit, because especially related to antibiotic use and the concerns we have with super infections and antimicrobial resistance. This is a big deal. And we're, I'm, last I looked, which has been probably a little over a year ago, I don't think there's much happening from the government as far as that goes. It's more the companies that are saying that they're going to do more about this. And from a consumer standpoint, the best we can do is avoid those types of meat products where they're using hormones and antibiotics. And the hope with that is, you know, when there's no demand, that hopefully that will cease to be an issue, but it certainly is a problem.
Right. It does not look like we have any additional questions. I think people need time to take in all of the information and marinate on it, right? So Kelly, do you have any final parting words before we close out today?
I just first want to thank Sigma for this opportunity, and secondly, thank all the nurses who joined me today. Your time is incredibly valuable, and I'm just really, really grateful to be here with you. I know that there's a lot of challenges that we're dealing with, and especially related just to medications. And so thank you for this time. And please do reach out to me if there's anything that I can offer. I would be thrilled. And I'd love to continue these conversations. So thank you.
Wonderful. Thank you, Kelly. We did share your email in the chat for people to reach out if they have questions afterwards. And we want to thank you so much for sharing all of this great information today. Sigma is grateful that you took the time to share with our audience, and we look forward to hearing more from you in the future. We hope that you enjoyed this webinar. As a reminder, we have updated our process, so webinar attendees can now access our learning management system right now to complete the evaluation and obtain your certificate. We have shared the link in the chat several times for you to access. Of note, you cannot click the screen to access the URL, but we will share it in the chat one more time for you. And as a reminder, you will receive an email with the link to the recording and the PDF of the slides, so you can access all of Kelly's great resources and information, and you'll receive that within about a week from this recording. Thank you so much for attending today, and we hope you have a wonderful day.